At this time, please begin the live stream of this meeting. Good morning.
Good morning. Good morning.
My name is Dr. Raquel Ingram, and I am the presiding officer for today's regular meeting of the North Carolina Board of Nursing Education and Practice Committee. The Education and Practice Committee meeting of the North Carolina Board of Nursing will now convene. We have a quorum for the meeting. This is an official meeting of the Board of Nursing conducted in accordance with North Carolina's Open Meetings Law under Article 33C, Chapter 143 of the North Carolina General Statutes. The board recognizes the public's right to attend and observe this meeting. As such, this meeting is being streamed on the board's YouTube channel, as well as being recorded. I'd like to remind everyone to please turn off all electronics or place them on mute for this meeting. In the event of an emergency, when an alarm is sounded or instructions for evacuation are given, everyone shall immediately exit the building at the nearest exits. Once you are outside the building, a staff member will provide appropriate instructions. The board's mission, vision, and values drive our work as a board and serve as a reminder to us as we carry out our business. The mission of the board is to protect the public by regulating the practice of nursing. Our vision is leading nursing regulation through exemplary nursing care for the public. In pursuit of our mission and vision, we focus on three core values. The first is equity. We adhere to the principles of fairness and consistency in regulation. Next is integrity. We act in good faith in protecting the public. And then agility. We champion innovative ideas and adapt to emerging healthcare needs. In accordance with the State Ethics Act and the Code of Conduct for members of the North Carolina Board of Nursing, it is the duty of every member to avoid both conflicts of interest and appearances of conflict. Does any member have any known conflict, interest, or appearance of conflict with respect to any matters coming before the committee today? Seeing none, or if so, please identify the conflict or appearance of conflict and refrain from any undue participation in the particular matter involved. And so now, seeing none, I will now move to the first part of the agenda, which is introduction and overview. But I'll pause for a moment and acknowledge Stacy Thompson for an announcement.
Good morning, and thank you, Madam Chair. I do have one announcement regarding the statewide tornado drill, which will take place today at 9:30 a.m. This alert is being conducted by the National Weather Service and will activate the state emergency alert system. If this were a real event, Board of Nursing staff would direct you to the location in the building for your safety. This alert may cause a brief pause during our meeting today and due to the alerts that the phones will receive. This week is Severe Weather Preparedness Week. For more details on the focus of this week's education, you can go to the National Weather Service website. I'd like to take this time to remind everyone of the resources available at ready.gov, and we encourage all to have their agency and personal emergency plans in place. Thank you.
Thank you, Stacy. Now, I would like to welcome all committee members and board staff, and also welcome to our guests who are observing today, and those of you who are on YouTube. Committee members, please remember to use the microphone when speaking so that attendees in the room and online will be able to hear your comments and questions. Now, moving to the agenda. Are there any additions, modifications, or reordering of the agenda requested at this time? Seeing no modifications, do I have a motion regarding adoption of the agenda? Dr. Steele has moved to adopt the agenda. Is there a second? Dr. Kistler has second. I will now call for the vote. All in favor by show of hands. And the vote is unanimous. And motion carries. Now for the approval of our November 12th, 2025 meeting minutes. Are there any modifications? All right, seeing none, do I have a motion regarding approval of the meeting minutes? Andrea Jepson has moved to adopt the meeting minutes. Do I have a second? Dr. Shaw has second. I will now call for the vote. All in favor by show of hands. And that's a unanimous vote. So that motion carries. All right. Now, agenda item number 3 is our open comment period. And we are now at the open comment period portion of our agenda. The purpose of the open comment period is to provide members of the public an opportunity to share their concerns, offer views, and present questions regarding issues that impact nursing and nursing regulation. Looks like we don't have anybody. Am I accurate? Okay, so at this time, we have no request to speak during the open comment period. Therefore, we will move to the next item, agenda item, which is agenda item number 4, the role of the medication aid. So the purpose of the Education and Practice Committee is to support the work of the board to review matters related to education and practice and to make recommendations to the board as charged. In January 2025, the Board of Nursing charged the Education and Practice Committee with exploring best practices related to the medication aid role to include providing education on the law, reviewing the administrative code or rules, and recommending revisions to the rules as needed. After hearing from board staff and external representative presentations at the November meeting, the committee directed staff to complete the following activities. The first was to revise the position statement for role clarity. Next was draft and amend rules as needed. Next was update and revise curriculum. And final was develop a plan for education dissemination to nurses in nursing homes. Practice staff have completed these activities and will present proposed revisions for the approval of training for the medication aid in nursing homes, in addition to resources to aid in clarifying the role for the public and licensed nurses engaged in the delegation process. For our summary of activities, Stacy Thompson will walk the committee through the materials and information in our meeting book. As we progress through the content of today's meeting, we will hear the presentation and summary of these key points. And I will now turn this discussion over to Stacy Thompson.
All right, thank you, Madam Chair. Good morning, everybody. As Dr. Ingram just said, in January of 2025, the board charged our committee to provide education on the law, review the administrative code rules, and explore best practices related to the medication role, which may include revisions to rules. So the committee has held 3 meetings thus far to conduct the work of this charge. A resource meeting book is available to provide important materials for reference and discussion. So before we start with the content, I want you to know that there are resources specific to the presented content in Onboard, and you can access those by clicking on Resources in the left toolbar. And then once you click that, you click on Education and Practice Committee, and then choose the role of the medication aid. And that folder has other state rules that have been added with informational documents for today's discussion. A summary of key points along with supporting documents for today's meeting are provided within the Onboard application within each agenda item. The page numbers for the meeting book are in the bottom right-hand corner of each page, or you can also hover at the bottom of the page in Onboard. Are there any questions about the specific resources for today's meeting? Okay. A review of the North Carolina Board of Nursing's jurisdiction and scope of work for the committee will now be provided. Medication aides in nursing homes administer medications through the delegation process by a licensed nurse after completing the board-approved training. The Board of Nursing's jurisdiction related to the role of the medication aid in nursing homes includes the delegation by the licensed nurse, med-aid faculty requirements, med-aid applicant requirements, and med-aid training and education materials. The Board of Nursing does not have jurisdiction over the specific facilities where medication aids function, as DHSR provides licensure requirements for these facilities. At the committee meeting held on November 12th, 2025, board staff presented a review of activities from the previous meeting, results from a medication aid instructor survey, a review of the current curriculum, and a summary of written comments provided by various representatives. To evaluate the impact of the current curriculum On the workforce entry, 3 guest speakers provided comments on their experience working with medication aids in nursing homes, and they addressed essential competencies for the role and also reported challenges that they face with medication aids upon hire. A key point emerged from the information shared and discussed at the meeting, and that was that additional work was needed to clarify the role of the medication aid in nursing homes, also to update the curriculum to support the adequate training of applicants, and recommend rule revisions to enforce specific requirements for faculty and training. The committee provided directions to board staff to first request an extension of the current charge into 2026, which was approved by the elected board on January 22nd, 2026. The second direction was to review and revise the position statement entitled Medication Aid Education and Role in Long-Term Care Skilled Nursing Facilities versus Adult Care Settings, to review that position statement for clarity. Number 3 was to review and revise the medication aid curriculum. 4, draft rule revisions for 21 NCAC 36.0406. And lastly, to develop a plan to disseminate the information to nursing homes. Medication aids in nursing homes play a vital role in allowing licensed nurses to focus on higher level decision-making by performing the technical task of medication administration. In upholding the mission of public safety, the North Carolina Board of Nursing must ensure that medication aid faculty and training requirements are sufficient to provide ample instruction to support safe administration of medications without creating barriers to this role within the workforce. Today's meeting will provide proposal presentations for curriculum revisions, for a process of medication aid training approval, position statement revisions, the education to be provided to nurses in nursing homes, and then rule revisions for 21 NCAC 36.0406 and 21 NCAC 36.0403. Within these presentations, you will see and hear evidence of the efforts of board staff to bring best practices and right touch regulation together to provide ample preparation to support safe medication administration in nursing homes. This concludes the summary of activities for the committee.
Thank you, Stacy. Are there any questions for Stacy regarding the summary of activities that she just provided? Right, seeing none, I will now turn this discussion back to Stacy for the presentation of the process for approval of medication aid training.
Thank you. The content for today's meeting will focus heavily on a curriculum revision proposal. To set the stage for understanding this proposal, we will discuss and compare the current approval process to the proposed process with rule implementation. A diagram is provided on page 8 of your meeting book in the document entitled Comparison of Current Process and Proposed Process. In the current process, an RN instructor candidate is educated by a master teacher on the role of the medication aid and the current scripted curriculum. Once this instruction is complete, the RN instructor submits an application to provide the board-approved curriculum. After that initial approval, the RN instructor must renew every 2 years at the time of RN renewal, provided they have taught a Med-Aid class in the previous 2 years. The proposed process is mapped in green and will shift from an instructor approval to a training approval. An entity who employs an RN to oversee the curriculum will submit an application for approval of Med-Aid training. The RN instructor will develop the curriculum for the Med-Aid training based on learner needs, current literature, and a Board of Nursing training content outline that will provide the minimum requirements for training. The RN may choose to add content to the training, but must provide a minimum of the content required in the outline. Each year, the RN instructor will complete an annual report to provide information related to enrollment, instructors, and curriculum changes to monitor and determine ongoing compliance with the minimum standards. In the next section of the meeting, the content outline and other resources for the instructor will be detailed further. So in summary, the transition from the process of instructor approval to training approval will facilitate three main changes. The proposed process will first eliminate the requirement for instructor renewal. Second, will allow the RN instructor to develop a curriculum tailored to the learners and be based on minimum requirements by the Board of Nursing content outline. And lastly, we'll be able to monitor compliance by way of the required annual report. So this concludes the information on the process of approval of medication aid training.
Thank you, Stacy. Are there any questions related to the process of approval for Stacy? Right? Yes. Dr. Steele, turn your-
Thank you, Madam Chair, and thank you so much. This has been great so far, Stacy. This particular question is not related to the process of approval, but of one particular thing you mentioned with the curriculum.
Okay.
Will we go into more detail a little bit later on the outline of the curriculum plan? Okay, I'll save the question.
Okay.
Thank you.
Thank you, Dr. Steele. Any other questions? All right, seeing none, we will now move to agenda item 6. Dr. Jenna Caparel will now present information specific to proposed curriculum revisions.
Thank you, Madam Chair. During the Education and Practice Committee meeting back in November of 2025, board staff presented a review of the current medication aid curriculum requirements. So in summary, the current medication aid curriculum was initially developed in 2005 with minimal updates in 2010 and 2013. The curriculum included a student and instructor manual that was last reviewed and revised in 2013. It included instructional DVDs to reinforce the manual content. It included a toolbox and a resource guide that was last revised in 2017. And it included a medication administration record in paper format. The curriculum requirement was a minimum of 24 hours of training. There was no required clinical component for that training. So in addition to reviewing the curriculum, board staff reviewed current nursing literature and rules of other states as it pertained to medication aids. That review of other states was quite extensive. We looked at over 40 states and we looked at what they defined as a medication aid or medication tech, whatever they looked at in terms of medication aids, and how they chose to define it, what they could and could not do in terms of medication administration, where they could or could not work, what the faculty requirements were, what the applicant requirements were, and also what the curriculum requirements were for those states. In addition, board staff developed a nursing instructor and master teacher survey that provided feedback, including challenges that instructors and master teachers faced while providing training to the medication aids. And there were 3 key findings from that survey, and it was that the curriculum was outdated, that there were some technological and resource gaps identified, and that delegation and setting misalignment role confusion existed, not just amongst the nursing instructors, but with the medication aids themselves, as well as with nurses that were working with the medication aids. So in addition, and what Stacy had already mentioned, we also sought out feedback from employers of medication aids working in the nursing home, and they were able to provide in-person or written commentary, and they identified priorities and areas of concern, which included role confusion, very similar to what the nursing instructors and master teachers had identified, between what the nursing aid could do versus what the medication aid could do versus what a med tech could do. They also had concerns about communication and documentation of the medication aid and their ability to multitask. Also, something that they specifically mentioned was that they were finding that the medication aids that they were employing had limited clinical experiences prior to starting work and also required extensive on-the-job training in addition to their initial medication aid training. So with all that information, the board staff since the November 2025 meeting has focused on additional research and updating that curriculum. This included developing another survey that was specific to curriculum and was distributed to the medication instructors as well as master teachers. This focused specifically on not just demographic data to have an idea of where they were working and what they were, and where the medication aides or the nursing assistants were working prior to, but also where the RN instructors were employed. We were also looking to get information on how long they had been teaching, what their average class size was. Were they offering a clinical component? So while the current curriculum requires a minimum of 24 hours, it didn't say that they couldn't incorporate a clinical component. It didn't say that they couldn't go above the 24 hours. So we were looking to see if they were including a clinical component, and if so, how many hours were they looking at? And then in addition, we were looking to get information on priority areas to focus the curriculum. Not to say that all that was listed that we asked about wasn't and isn't going to be included in the training content outline, but what were the key highlights they really wanted focus on? And so the entire survey results is located in your packet on page 12. But to summarize those results briefly here, we received almost a third response rate from the RN instructors and master teachers. So we received, I believe it was somewhere of like 87 or 88 responses. The majority of the respondents, so a little over 60%, have been an RN instructor or master teacher for less than 7 years. So they're fairly newer to the role. About 20% had a class size of 1 to 3 students, 40% had a class size between 4 to 7 students, and 40% had a class size of 8 to 10 students, which really impacts when we think about a 24-hour course requirement currently. When you only have 1 to 3 students, you might be able to teach a little bit more and focus on certain key content areas versus if you have more students, that might not be enough time, which was the feedback we got from the initial survey. 85% of the respondents did not offer a clinical component or any direct patient care experience within their course or their training, but 15% did offer it. So you can see from the results survey of that, about 3/4 of those that did offer a clinical component offered anywhere from, could be 30 minutes to 4 hours for their students. The top 5 priority topics identified in order by those medication instructors as medication aid instructors and master teachers were medication documentation, role of the medication aid, what to report to the nurse, routes of medication administration, followed by legal and ethics issues. So in addition to the survey, board staff also reviewed NCSBN available resources and states where boards of nursing have rules and regulations as it pertains to the medication aid working in the nursing home. So we took that big research that we did on the initial medication aids working in all the states, and we tried to narrow it down to what states had the boards of nursing developing that curriculum for those medication aids, working in that specific environment to help provide a framework or really a guideline, if you will, for how we could approach how we develop our rules and curriculum requirements. And so with that, we found that, I believe in the supplemental material in your packets, there is a list of those 4 states that we looked at. We looked at others, but 4 states that really helped, I think, outline what we were trying to go for our curriculum training checklist. And we had anywhere from required hours of 40 to 100. And that could be divided however the states chose to do, 40 hours didactic versus 60 hours didactic, 40 hours of clinical, 20 hours of direct patient care or direct patient care experience. And so that was helpful and informative, like I said, in helping us develop our training content. So now moving into the actual content outline. On page 18 of your packets is the proposed training content for the RN instructors. And that includes an increase in the education hours. So we are looking at taking this current curriculum from a 24-hour course with no clinical component to a 40-hour didactic instruction course with an additional 20-hour clinical instruction component. So you will see that we're having a max of 10 students for that didactic instruction. And with the 20 hours of clinical instruction, we're looking to have an instructor to student ratio of 1 to 2. That will allow for there to be dedicated, focused time for those medication aids to get that experience prior to working in the nursing home. As we found, the employer's concern was that they were coming out with no real hands-on experience. So this will hopefully help meet that need in the community and improve safety in terms of having that experience to begin with. You will also see the subject areas for the medication aid training outlined. I'm going to briefly give examples of what each subject area's content will be. This is not all inclusive. It's not limited to what I'm saying for those that are watching from home. So just giving you an idea of what type of material will be covered in each subject area. So the first subject area will be the roles and responsibilities in the nursing home. This will include Board of Nursing and DHSR laws and rules, resources, and roles of the medication aid and the nurse in delegation. The second subject area will be the legal role and responsibility of medication administration, and this will include patients' rights, medication errors, discussion about fraud, diversion, and negligence. The third subject area of medication aid training will be the fundamentals of medication administration, and that will include the use of protective equipment and the 6 rights of medication administration. The fourth subject area will be basic introduction to anatomy and physiology. Again, basic, minimum will be just what we have currently in there is an introduction to disease processes and body systems. The fifth subject area will be medication administration procedures, and this will be the meat and potatoes of really what the medication aid will be doing. It will address medical terminology and abbreviations, the differences between scheduled and PRN medications. It will address routes of administration, documentation, and then methods of distribution, how medications come packaged. The sixth subject matter subject area will be population-specific care, and this will include life developmental stages, addressing some of the unique and specific needs of the residents in the nursing home setting. And then the seventh subject area will be population-specific medication classifications and relation to body systems. So we will look at, or we will have the nursing instructors focus on teaching the differences between vitamins and supplements versus prescribed medications for, infection, precautions that need to be taken, the differences between generic and brand. They don't need to necessarily know every generic or brand, but they need to at least know what the difference is. And so in addition to that training content outline, we will also provide instructors with a medication aid instructor toolkit resource. And that is on page 17 of your packets. It's a draft and an example of a resource that I think will be helpful for new instructors coming in terms of what types of supplies they can use to help facilitate teaching their course. Additionally, it's not included in your packet currently, but there will be a revision to the current medication administration competency checklists that are located on the North Carolina Board of Nursing website. These are within the medication administration modules that are designed for RNs or LPNs, RNs to help work and develop those skills for UAPs in general. But we're going to pull the medication administration checklist and have that be utilized within the actual training content for medication administration for these instructors. So with all of that said, and all that work we've done from November to now, in January of this year, the board staff presented this, what I just spoke about, the proposed curriculum updates and how we got here to RN instructors and master teachers. And we had approximately 20% attendance for the live presentation. It allowed the instructors also the opportunity to post questions to the board staff, and we were able to provide a response summary to their questions, and that is located on page 15 of your packet. So in summary, instructor surveys have provided insight into current challenges regarding medication administration, medication aid instruction, and identified priority areas for improvement. We reviewed other states' curriculum requirements for medication aids in nursing homes, and that helped provide a framework for training outlines and standards that we developed here. And then the increases in didactic instruction and the addition of the clinical instruction time will help to facilitate not just the recommended curriculum update, but also to address the concerns identified by both the instructors and the employers of the medication aids. And that concludes my section here.
Thank you, Dr. Caparel. Are there questions related to the proposed curriculum revisions? Right, that was good. I'll turn it back over to you, Dr. Caparell, to provide the proposed revisions to the current position statement specific to medication aids.
Yes, thank you, Madam Chair. Now we will transition to the position statement. So following the meeting for the Education Practice Committee in November, the committee directed staff to review and revise the current medication aid education and role of the medication aid position statement. So included in your packet on page 21 is the current position statement, followed by the revised position statement on page 28. Feedback provided by medication aid instructors and employers included role misalignment and confusion amongst nursing staff and medication aides. Taking that into consideration, the board staff reviewed the current position statement to address that feedback. While there is no recent law or rule changes as it relates to nursing delegation to medication aides in the nursing home, the revised position statement focuses on providing an overview of the medication aid role in nursing homes compared to medication technicians working in adult care settings. It identifies the agency responsible for regulating adult care settings. There's an emphasis on the medication administration task as ordered by the authorized providers and delegated by the licensed nurse. And it clarifies which medication aid activities the licensed nurse may delegate in the nursing home and identifies tasks that they may not delegate. So in summary, the position statement emphasizes, the revised position statement emphasizes the delegation of the task of medication administration to the trained medication aid, the responsibility of supervision by the licensed nurse, and what the licensed nurse can and cannot delegate based on current law and rule.
Thank you, Dr. Caparell. Any questions for Dr. Caparell related to the proposed revisions of the position statement? Yes, Dr. Shaw?
Is there any opportunity in the position statement to say where medication aids may not practice in or work in? And I say that because when we say nursing home, is that the same thing as long-term care? And so in some acute care hospitals, there might be units within a facility of an acute care hospital that is licensed for long-term care or nursing home. So in those situations, I'm assuming a medication aid can work on a unit that's in a facility that is licensed for those beds specifically to long-term care. A medication aid can work in those settings. Those are real questions, and if we can clarify that in these documents, that would be great. Thank you.
Yes. So the answer to your question is yes, because it may be within a large healthcare system, but it's possible to have different types of licenses within that healthcare system. So you may have one license for a home health within the health system. You may have a license for a long-term care facility or a nursing home. So the reason for the terminology of nursing homes is because it comes down to how that facility is licensed by DHSR. So that's what determines whether this med-aid can work there. And the Board of Nursing doesn't have jurisdiction over that facility, which is why that's not specifically spelled out in our position statement. However, you'll see when we get to looking at the rule revisions that is very well defined as an area where the training can be offered.
Okay, so I want to clarify, if hospital A is an acute care freestanding facility, it has, I'm going to say, 350 beds, and there is a unit 2 West, this is not real, 2 West, and that is a licensed, out of this 350 beds, that's a licensed unit dedicated to long-term care. It's a long-term care license for that specific setting care of patients, but it just happens to be embedded in a 350-bed facility. So my question, I want to just clarify based off of your comments, is a medication aid can work on 2 West, which is inside of a freestanding acute care hospital that has 350 beds.
So the location is not going to determine the type of license will.
So I think those are real, situations, and I don't know if there's any opportunity to further clarify that, um, you know, as employers read through those position statements. And I only say that because then I do get questions, can a medication aid work in an acute care facility, just for those reasons, right? And they don't know why. So I think that would be great clarification.
Great questions, Dr. Shaw. Additional questions? Discussion? All right. Do I have a motion to approve the position statement entitled Medication Aids in Nursing Homes, Role of RN and LPN, and direct to the full board in May? Yes.
So if Dr. Shaw just made the recommendation to add the clarification, do we need to wait to approve for after, or make the motion to direct them to consider adding the clarification and then we vote in March? Or would it be helpful to vote now with just that piece and then, yeah, I just need some clarification.
Great question, Dr. Shaw. Sorry, Dr. Steele.
On the draft of the position statement, in the first paragraph, it talks about DHSR is responsible for the licensing of the facilities. But we can provide further clarification in that area just to reference that how did you just say it?
License is based on the license.
It's based on the license of the facility and not the location.
You might want to say license of setting, right?
Okay.
And maybe facility. That's a setting within a facility. I don't want to get too technical. Maybe we can take it offline, but I think some clarification would be great.
I think we can work on that before the end of the day and have some, an edit to this document, but we have to also look at DHSR's regulations to make sure that we're using the correct terminology with that as well.
I would recommend that we table it for now and come back to it.
So Madam Chair, I move that we table this vote until the end of our time together today.
Thank you, Dr. Steele. Dr. Steele has moved to table this. Is there a second? Seconded by Kelly. All in favor by show of hands. And the position statement approval has been tabled. Now we will move to agenda item 9. Dr. Caparel will now continue our discussion with a presentation on education to be provided to nurses working in nursing homes.
Thank you, Madam Chair. So based on the comments provided by RN instructors and master teachers and employers during our previous November Education Practice Committee meeting, an area that was consistently identified as a challenge was role misalignment or role confusion amongst employers and nursing staff within the nursing homes. Board staff developed a dissemination plan to provide education to nurses working in the nursing home setting. The goal of this plan is to reduce role misalignment and role confusion amongst employers and the nursing staff within these facilities. The dissemination plan will include a fact information sheet with a draft provided on page 31 in your packets. that provides clear and concise guidance for nurses working in the nursing homes. And this will be provided to state stakeholders that work specifically within the long-term care facilities and the nursing homes in North Carolina. The information will emphasize the distinctions between medication aids and medication techs, and between nursing homes and adult care settings, based off of what we also discussed with this position statement, and being more specific if we need to be about the licensure requirements, and the role of the licensed nurse in medication aid delegation, with the routes of administration and delegation parameters being emphasized. Following that fact information sheet being sent out to state stakeholders, there will be a presentation available on the Board of Nursing website that will include updated rules and regulatory requirements with references for nurses who work in these settings, the medication aid in nursing homes position statement, the medication aid curriculum updates and competency requirements, and then practice-based scenarios and frequently asked questions that will help, I think, further clarify the role of the medication aid and the role of the nurse in the delegation to that medication aid. Additionally, there is a plan to have a practice corner in an upcoming issue of the bulletin that highlights key concepts and practice guidance for the nurses working in those settings and delegating to the medication aid, as well as a social media post to link directly to the updated position statement that will help increase visibility and accessibility to the information. So to summarize, role confusion amongst nursing home staff was consistently identified as a challenge, particularly regarding differences in responsibilities between the medication aid, medication technicians, and licensed nurses. The goal of this plan is to improve understanding and alignment of nursing roles in the nursing home, which supports safer and more consistent practice. And board staff developed this dissemination plan that helped to address and clarify the role distinctions, delegation responsibilities, and medication administration parameters.
Thank you, Dr. Caparel. Are there any questions related to the presentation of education? Right, seeing none. Now, it's kind of break time, but we can continue if everybody's okay. Yep, okay, all right, so.
Next part's gonna be long.
Okay, and that's what I was thinking. The next part is rule revisions. And so we might want to just go ahead and take a break, and then we can come back and get into these rule revisions. Okay, so it is, we'll take 15 minutes, so we will resume around 10 o'clock. Thank you. The Education and Practice Committee meeting is now back in session. I will now ask Stacy Thompson to lead us through the draft of revisions for the current Rule 21 NCAC 36.0403 qualifications. Well, Dr. Ingram is a little bit ahead of herself. We will ask Stacy to instead lead us through the rule draft for medication aid training requirements to be provided, which is 21 NCAC 36.0406, medication aid training requirements. Thank you, Stacy.
Thank you, Madam Chair. The current rule for medication aid training requirements is provided on page 33 of your meeting book. That's a rule that is currently in place. The current rule outlines the instructor qualifications and the requirements for initial approval and reapproval every 2 years for the RN instructor. Through the work of reviewing national standards, in addition to rules of other states addressing medication aids in nursing homes, a revised draft is proposed to clearly outline the requirements of training for the medication aid in nursing homes. The proposed rule revisions for 21 NCAC 36.0406 are located on pages 34 through 37 of your book and incorporate instructor requirements, applicant requirements, and training requirements. So we'll talk through each section of the proposed rule in the context of the proposals you've heard so far, specific to the approval process and the curriculum content. So I'll pause after each section, after giving you a summary of the section, so that if you have a question about that specific section, you'll be able to ask it at that time, okay? So first, you see that the proposed title change of the rule is now going to include in nursing homes, which provides clarity to whom the rule will apply. Next is an implementation date of January 1st, 2027. That is set to provide clarity around the transition from instructor approval to training approval for current med aid instructors. Any questions about those two portions? Okay. Section A details the entities that will be eligible for training approval, and that will include proprietary schools, licensed care facilities or nursing homes, and educational institutions within the North Carolina Community College system. Section B requires the entity to employ an RN to oversee the med aid training, who will have the authority and responsibility to comply with the rule. Section C, instructor qualifications are listed as having an active unencumbered license or a privilege to practice in North Carolina and a minimum of 2 years employment as an RN. Section D requires an application to be submitted at least 60 days prior to the proposed training start date and prohibits the entity from soliciting students until the training is approved by the board. Section E outlines the information required on the application, and you'll see all of those listed there. A lot of it's demographics, but then specific to the registered nurse instructors information, clinical site forms, the admission requirements for the learners, the maximum projected learner enrollment, and a training syllabus that has the required components listed. Section F provides the minimum applicant requirements, which are that the learner be listed on the NA1 registry and have a minimum of 1,000 hours of continuous work experience as a NA1 in a nursing home. Section G outlines the minimum curriculum content requirements, as you heard in the curriculum revision section of today's meeting. And you'll see those subject areas detailed out in Section G. Section H, the states the maximum number of learners per class is 10. Section I outlines the minimum requirement of 40 hours didactic content and 20 hours clinical experience. Section J outlines the requirements of the clinical experience so that on-site supervision by an RN providing training instruction at all times, a maximum ratio of 1 RN to 2 learners, and the learner must demonstrate med administration consistent with board-approved competency skills checklist and must support the curriculum of the training for medication aids in nursing homes. Section K requires any change of the curriculum to be approved by the board. Curriculum changes must be submitted at least 60 days prior to proposed implementation, and a change in an RN instructor at least 5 business days prior to the change. Section L outlines the requirements of the annual report and what information must be included. So you will see 6 different pieces of information, specific about the enrollment, how many students completed the training, the information on the registered nurse instructors, the name and location of all the clinical agencies that are used, and then testing to compliance with this rule. Sections M and N outline the process of resolving noncompliance within Med-Aid training. This process would include a notification of noncompliance to the RN instructor by the board, so that the RN instructor would then provide a request for change to acknowledge the areas of noncompliance and how they will be remedied. And then upon the review of the request for change, the board will either approve the change with no further action or deny the change, at which time the Med-Aid training will no longer be permitted to offer the training, and the RN instructor will cease operation and notify the board of the closure plan. If the RN contests the denial, a request for hearing before the board may be submitted, and the board shall determine at hearing whether to grant the request for change or cease operation of the training. Section O provides an entity offering the training where learners have not completed the training for 2 consecutive years will be deemed closed. Section P, when a training closes, the RN instructor must notify the board in writing within 30 days of closing, informing how learner records will be stored. And then lastly, Section Q, a list of board-approved Med-Aid trainings will be posted on the Board of Nursing website with contact information provided. I'll open it up to questions.
Any questions or points for discussion? Yes.
I know under bullet F, it's for 1,000 hours in a nursing home setting. If we actually have CNAs in our facilities, hospital facilities that are looking for just a slower pace, different change, will a hospital setting work as well, or is it specifically nursing home?
The way the rule is written now, it would need to be in a nursing home, and that 1,000 hours is equivalent to about 6 months of full-time work.
I have 2 questions for the curriculum. I just want to clarify. Is it once it's approved for permanently, or is there any, quality checks at some point that there's a review of? And I know there's an annual report, but is the annual report intended to kind of do a guardrails around the curriculum and ensuring that it's still appropriate?
Yeah, so the quality comes in with the RN being able to update their curriculum as they need to. So the way we would monitor that is they're required to do a request for change. Once they're approved, they are improved indefinitely.
Okay.
But they are required to get approval of any changes that they make. So that's one way to monitor the quality, but also the information that we get in that annual report. If we see, several trainings are making the same changes, that's pretty indicative that that's something that we need to look at to see if they're adding something to their curriculum that now needs to be within the minimum requirement. So we've tried to kind of build in that multi-layer check so that we stay up to date, but it gives the RN instructor the ability to do the assessment of the facility or of the learner to be able to devise an educational plan that's going to meet the knowledge gap.
Okay, thank you. And then, when it said 10 max per class, so does that mean a class can only have 10, or can you have 2 instructors with 15 students? You know what I'm saying? Is that is that one, are we saying when we do any training, it cannot have any more than 10 students, or are we saying it's 1 instructor per 10 students? I just want to clarify that point.
That's a really good question. The way it's written right now is it wouldn't matter the number of instructors, there would only be 10 learners per class. And the thinking behind that is because of the content that we're providing in the outline, just a better set. That is the current requirement right now, is that the class have no more than 10. But it gives that one-on-one experience. Plus, with the clinical component only having a ratio of 1-2, it helps to manage not having to extend the class out for a long period of time and still being able to move students through it. It's not to say that they couldn't have 2 classes running concurrently with 2 instructors with a class of 10 each. They could run 2 classes at the same time. But there really needs to be only 10 class is how the rule's written, but y'all to discuss.
Yeah, I mean, I think there should be a little bit of flexibility. I understand the maximum amount. So if I was in one big room, we can all be, for efficiency purposes, using the same training. But there are 2 instructors, to your point, to answer questions and, whatever you were just articulating. So I didn't know if that was totally the max, or there was an opportunity to have that flexibility of perhaps 15 students and 2 instructors. Just trying to, I understand it could be parallel um, courses, classes, but that might not make sense. But that's just my opinion. Thank you, though. I get it. I just want to clarify.
Well, it's certainly a topic for discussion if there are other thoughts around that section.
I think it's a great question, Dr. Shaw. I also see as a scenario, a classroom with 20 students, 2 RNs. This RN is responsible for this 10. This RN is responsible for this 10. And so it's still the 1-to-10 ratio in that scenario.
Yeah, and I think that's what I was saying. Is that permitted?
So with the way the
But you're saying
proposed
no.
rule is not
Right.
written that way. If it's the desire of the committee to change that to a ratio rather than a max number per class, that would be something that you could discuss.
Was the idea in writing the max of 10 per class to consider the ratio of 1 instructor per 10 students? Was that the spirit of the rule or
Well,
the policy?
it was several things. That's how current med-aid instructors are running now, with a maximum of 10 students per class. But also considering the requirement for the clinical ratio being 1-to-2, to be able to not allow so many in one class that it takes a long time to get through the clinical portion. But, it's it's you guys' decision on whether you would like to have a maximum per class or if you would rather that be a ratio.
I mean, I can support a ratio because I've been in those situations before where you have, you know, a max of 10 per person, per instructor, or really 5. But anyway, when you get to 6, you have to have another instructor. So you have to make, as the leading body, you have to make the decision of whether or not it's worth it to have 2 instructors for 6, in this case 11, versus 1 for 10, and you would max out yourself. But if there is an opportunity to have in that scenario, then, you know, you don't want the rule to be so restrictive that it prevents the class from taking place. And then, of course, you do get into, so here's the other side of that. If you do 1 to 10 ratio versus class max size, then when you get to the 11, 12, 13, 14, 15, and supervision, and what if the teacher is absent, and then you have 1 to 15, does the class not meet that day? What happens with the sub? If there's no sub, then what do? Do you still teach? And then what if it's long-term? Like, these are all the things a leader of the school would be thinking about. So I do see the benefit of saying no more than 10, because it also is a ratio consideration as well, which is the 1 to 10. And it wouldn't be a problem if, you know, the teacher is absent, because at that point you've got a regular, you know, your regular things that you're dealing with. But when that second instructor is absent over 10, you've got a real big problem. And then we have to regulate that. So what I'm saying is I could see the both, you know, being an option, but in this case, to not overcomplicate matters, maybe the max class size of 10 is sufficient. That's my opinion.
Or I would say, have the flexibility of the ratio. And it just allows, if those, I think, situations do arise where there are more student opportunities for more students, that there's a flexibility to have, you know, 1 to 10 ratio versus a max. I mean, I think the risk is low for what you're talking about, because we're talking about training, you know, we're not training nurses, we're training around the curriculum, or we're training medication aides. Oh, well, we're training medication aides. Okay. I'm thinking instructor, because I was like, that might not be a lot. Yeah.
Assistant.
I mean, I guess, does our data show that we will have an increase in medication aids? You know, yeah. I like flexibility, which, if we're talking about rule change, we're not going to be able to change the rule too frequently, correct?
Correct.
So I would move towards having more flexibility, you know, a ratio versus a max for those purposes. You know, as I can see companies wanting, you know, maybe doing mass training, you know, and it might be 15 to 18 students or trainees. So I would propose that we have some flexibility, move to a ratio for the purposes of, these are rules that we can't just change, you know, frequently.
I support that for that very reason.
So I would like to add, when I look at this, so the scenario that I gave was related to nursing education, how we do in when we take students to clinical, you know, so we have that 1 to 10 ratio. And so we wouldn't, well, we could have an instructor absent for clinical. And if we do, we would have to do something different, you know, because we couldn't have a 1 to 15. But in looking at item J, where we have the registered nurse to learner ratio of 1 to 2, if we did the ratio that is being proposed, how does that impact that?
If we say a ratio of 1 to 10, it doesn't change that at all.
Okay.
If we increase the maximum class size, that will affect that.
Okay. So if we say a ratio of 1 nurse to 10 students, this is okay.
Yes.
That doesn't impact that. And so before any other discussion about that, because I have another question. So L, where we have the name, address, location, all of those things, the number of students, we don't have a list of the students. And so do we need that for when this is submitted? Would it not be good for us to also have a list of the students who completed the training?
So the Med-Aid registry is with the HSR.
Right.
So I don't know what we would do with that information. What we would look at is, does the enrollment match the number that completed? So is the training successful in getting them to pass the exam? And we would also look to see, how many med-aids that we're able to train each year. So, and hopefully, year after year, that shows that number increase. But as far as the individual names of the students, no.
Okay. And I kind of thought that, but it just seems like it would be good in the case that within the collaboration, some record checks are needed, we would at least have something, but I get it that that's out of our jurisdiction. Okay. Yes, Dr. Steele.
So, good morning, once again. My question is around the curriculum. So, I come from a position of doing more prescriptive curriculum writing, and I noticed that this training plan could be just a little bit outside of my normal scope of reviewing curriculum. So my question is, in the nursing space, is it customary to provide the outline and then allow the nurse educators to then take it and run with it? And they automatically know, for instance, under overview of medication aid role and responsibilities in nursing home, if it says DHSR law and rules, they know which laws and rules to cover, or to cover the entire thing, and to understand or help their students understand certain points that are, I guess, more important than others, or just understand it all. They already know this.
That is a very good question. And in that content outline, that's kind of a placeholder. But when it is approved and provided to the instructors, it will have the specific rules in the outline as to
Okay.
what applies.
That was
And
my
they will
question.
be linked so that the
Mhm.
instructor can access them easily.
Okay, so perfect, because when you get down to things like the legal role, negligence, fraud, and diversion, I wanted to make sure that you highlight, or we highlight, or someone ensures that they're learning this about negligence and this about fraud and this about diversion, so that the important points are taught and communicated. But then also, you don't want to make it too restrictive to where the instructor has no flexibility to add to those things based on his or her real life experience, and then also their, relative research. And then, of course, if you do make it too prescriptive, sometimes people only teach that and they just forget that they have flexibility to add any additional items. So I just wanted to just confirm that it was customary to be this way. And then I do want to applaud you all for doing what maybe people may consider basic, but taking all of the topics of the outline and including those topics as the outline for the curriculum in the proposed rule in order. That matters, because sometimes I think people confuse or conflict the curriculum, and they'll have it all orderly, like on the colorful, outline that makes it easy for us to read. But then in the document itself, the rule itself, it'll be scenario driven or larger topics, and it won't be as specific. So I do thank you for that, because I went back and compared every last one of them and they're all accurate. So good job. That's all.
And I will add, as we roll this out, we look at the process, and part of the process outline on that diagram that we went over to begin with, we will have a recorded kind of instruction overview for the instructors when their training is approved, to give them some overviews about the laws and rules that are very important, the purpose of the position statement, just to give them that overall introduction to being a Med-Aid instructor. It won't be required, but it will be part of our communication to them and made available. So that's just an additional resource to help support the content outline, so that it is easier to understand what needs to be under each topic.
Additional questions, discussion? Dr. Kistler?
I've thought a minute about a previous one, so I'm going to go back to the 1 to 10. The only thought that I kind of had stemming from that is in regards to mass education, the 1 to 10 with 10 being max. I think maybe we would need some literature that would support whether or not a class of 40 with 4 instructors is appropriate. In teaching med aid at the community college that we teach at, it is a lab-based, hands-on. 20 students in a lab space actively doing things sometimes is difficult to manage. Our instructors actually like 6. And because 6 meets our financial number, we can actually run it with 6, even though we have a 10 to 1. So there's always going to be those numbers because the financial component and how much money are we making is going to be a contributing factor. So I could see where they're like, you can do 1 to 10. Let's maximize it at 20. But is there anything to support within one environmental area? Are we actually doing best practice? The biggest thing for me is the 1 to 2 clinical ratio. Most of our long-term care facilities are not large enough to sustain 20 plus students within one class. So essentially what we're going to have to do is extend the class to meet those 20 hours for each additional student, which means the students who it would just make the classes longer. But again, that's an operational side that we can manage on our own by allowing the flexibility. So I'm not opposed to allowing the flexibility of 1 to 10. Just want to throw some of those other constraints out there when you look at mass training of large groups within one small area. There may be some best practice guidelines. We want to say you don't want 40 students in one lab space. That may not be effective. Hopefully we're good at evidence-based ourselves and make that proper choice, but there's still that opportunity.
Yes, absolutely. Thank you, Dr. Kistler. Those are great considerations.
Just a quick thought.
Yes,
Most of the
Dr. Steele.
people, the respondents of the survey, cited that most of the courses or the classes that they teach are taught in community colleges. So is that pretty consistent around the state? I know we didn't get a full sampling, but is that consistent?
It's hard for us to know because
Right.
right now we're just approving the instructor and we don't have any information on where they're teaching other than what they told us in the survey.
So on that note, from a data gathering perspective, I think it would be good, because we're first in flight, first in nursing, all over the nation. I think it would be good to gather information as we start approving instructors or recertifying to go ahead and have them identify where they're teaching. So basically
Yes.
some of the tenets of the survey include that in the requirement for them to get certified, approved, recertified, et cetera, so we can keep up with the
Yes,
population.
that is a part of the application and it'll be a part of the annual report.
To be clear, Dr. Steele, we will be moving away from approving the instructor to move to approving the training, the curriculum, everything that's opposed or everything that's related to the program itself or the training course. Is that
Right.
All righty.
So we will know
Mhm.
what training is being provided and where it's being provided
Location.
with the new process, yes.
Got it. Okay, understood.
Additional discussion? Yes.
Okay, so how will you know the humans who are teaching the courses in those locations?
They will have to provide that information in the application,
Oh, okay.
anytime it changes, and also in the annual report.
Okay, so school A says, we have 6 instructors, here they are, here are their names, et cetera. But the site is community college, school A. And here are all the things we're teaching and blah, blah, blah. Okay,
Mhm.
all right.
So just going back to item H, the maximum number of learners shall be 10 per class. Just listening to the different scenarios. So the 1 to 10 ratio was something that we talked about. And I hear you, Dr. Kistler, in terms of the community colleges typically where the medication aids. are trained. And so with that, I think about the labs and the mass training and then the clinical component. At the same time, Dr. Shaw, I hear you about the flexibility. And so I summarize that mentally, if you will, in terms of the safety, and the competency. And so I guess I'm entertaining or asking, where should we go with this? Are we wanting to propose this 1-to-10 ratio, or are we wanting to leave it at the maximum number of learners shall be 10 per class?
I think for flexibility, the 1-to-10 ratio would take care of both. Because a school may or may not, because we could put a sub-note or a note that says it is recommended that you do 10 per class. However, the flexibility of the rule states 1/10 ratio based on your space and capacity or something along those lines. I don't think it's inappropriate to offer a note of explanation of the flexibility. But I think 1-to-10 accomplishes both. No more than one instructor per 10. But if your space does not allow for a maximum, even, some people may have to be at 8 or 7 just because of space constraints. So
Yes.
then everyone has the flexibility, because when you look at a system like, a larger hospital system or a larger group, they may have massive spaces to be able to accommodate, and then they may use that space to their advantage, thus hiring more staff to come in and provide additional ratios. Additional meeting, thus providing more staff to be able to meet additional higher ratios. So I don't think we should limit the smaller group schools nor the larger schools/institutions.
So if there is not further discussion, I believe that I have to, I'm looking at Mary, have a motion for, do I just go with the motion and add the amendment, or do I have to?
Madam Chair, I move to accept the proposed rule with the added change of 1-to-10 ratio and an added note regarding maximum recommended class size.
Well, if I can put some information to that, because of the rulemaking, we wouldn't be able to add a note there. That might be something that could go on the application for training. It could be the note could be incorporated on the application. But I would stick to the 1-to-10 ratio that you had mentioned and then take the note off.
There are no appendices or anything like that.
Not for rulemaking, but you could direct staff to add that note and clarification on the actual application itself.
Okay. Madam Chair, I'd like to amend my motion and clarify that I move to adopt the rule as in its current state with the proposed change of 1-to-10 ratio in place of the maximum class size of 10.
Okay, thank you, Dr. Steele. Dr. Steele has moved to approve the rule with the amendment of the 1-to-10 ratio. Do I have a second? Andrea Jepson has second. All in favor by show of hands? And this committee, okay, so the motion carries. Thank you. All right. Now we will move to
Madam Chair, I'm sorry.
Mhm.
I did not state the rule 21 NCAC 36.0406. So I think that bears stating for the record.
Okay, thank you, Dr. Steele. For the record, the approval was 21 NCAC 36.0406, training requirements for medication aids in nursing homes. Yes.
Madam Chair, if I could just add a point of clarification. In terms of the rulemaking process, these amendments, the rule as amended just now will be going to the full board in May for approval to proceed with rulemaking.
Thank you, Meredith. All right, if there is not anything else with this, we will now move to agenda item 11, rule revision draft for 21 NCAC 36.0403, and I will turn this over to Stacy Thompson to lead us through this.
Thank you, Madam Chair. So while 21 NCAC 36.0403 was not a rule that staff was directed to revise, the need for this revision emerged through the drafting process of 0406. So drafted revisions are provided on pages 38 and 39 of your meeting book, and the changes are highlighted in yellow. So this rule provides the qualifications of the NA1, NA2, and the Med Aid roles. In section D on page 39, reference is provided to a general statute from DHSR specific to the medication aid. And through our discussions with legal staff, it has been proposed that this section be deleted. The Board of Nursing jurisdiction is specific to the requirements for the faculty, applicants, and training. So as a result of the deletion of section D, a title change of the rule is proposed as qualifications of nurse aid. So that concludes the proposed revisions to this rule.
Thank you, Stacy. Any questions or points for discussion specific to this draft? Okay, all right, seeing none, do I have a motion to approve the revisions to 21 NCAC 36.0403, qualifications of nurse aid, and direct to the full board in May?
Madam Chair, I move to accept the proposed rule change of 21 NCAC 36.0403, qualifications of nurse aid, and to direct to the board for full approval in May.
Thank you. Dr. Steele has moved to approve the revisions to 21 NCAC 36.0403, qualifications of nurse aid, and direct it to the full board in May. Do I have a second? Dr. Kistler has second, and I will now call for the vote. All in favor by show of hands, and it's unanimous, so the motion carries. All right. Now, we had tabled the position statement for medication aids in nursing homes. You all have been provided with the updated revision. You'll see under issue where in blue it is highlighted. And I'll start from that second sentence. North Carolina Division of Health Service Regulation, or NCDHSR, is responsible for licensing and regulating healthcare facilities, including nursing homes and adult care homes, and is additionally responsible for the regulation of medication aids. And I'll stop there in terms of the revision. Are there questions or discussion about that? That first paragraph. Questions, discussion? Not too far ahead if there are additional questions. Yes, Dr. Shaw.
When we say does not have jurisdiction over the facility or the medication aid, that's just, what does that mean again? And for the medication aid part.
So the Board of Nursing's jurisdiction is not to say what the med aid can do or what the med aid can't do or what facility can do certain things, but only to say what the nurse can delegate. So that's kind of the realm of our jurisdiction. So the licensing and the registries and what they are not allowed to do are going to be determined by the license of the facility.
So they would just, basically, it would just be treated as any other unlicensed assisted personnel that's in the facility, with kind of the same thing, right?
Well, it is an unlicensed assisted personnel, but that this person has had specific training for this particular skill.
Okay.
So it's kind of outside your nurse aid or nurse aid 2 or that, because the initial training is different.
And
But it would still from the nurse's perspective, it would still have to meet all of the criteria for delegation as the nurse is delegating the medication administration. So the criteria doesn't change for the nurse to consider.
Mhm.
It's the competencies and the training of that med aid is what's different.
Who is a nurse aide,
Yes.
but which we have jurisdiction over. Nurse aide
No.
one? No? Okay. Okay. All right.
Dr. Shaw, in
Please
addition,
confuse it.
the med aid is also required to list on the medication aid registry, which is housed and regulated by DHSR.
Additional questions, discussion? All right, seeing none, is there a motion to approve the amended position statement entitled Medication Aids in Nursing Homes, Role of RN and LPN, as I read previously, and direct to the full board in May?
Madam Chair, I move to accept the revised position statement entitled Medication Aids in Nursing Homes, Roles of RN and LPN, and direct to the full board for adoption in May.
Thank you, Dr. Steele. Dr. Steele has moved to approve the position, the amended revised position statement and directed to the full board in May. Is there a second? It has been seconded by Andrea Jepson. I will now call for the vote. All in favor by show of hands. And that is unanimous. Thank you so much. And now, okay, so we are now at agenda item 12, committee discussion. So with committee discussion, I just want to thank the board staff for providing the meeting books and for the extremely informative presentations. They were very detailed. I would also like to thank the committee for your questions. It was a great discussion. You brought out some great points, and I will turn it over to Stacy Thompson to provide us with a summary of the pertinent points that were presented today.
Medication aids were approved to administer medications in skilled nursing facilities such as nursing homes in Senate Bill 622 in August of 2005. Since the law became effective on July 1st, 2006, licensed nurses have worked with medication aids and have delegated the administration of medications as ordered by an authorized provider. Delegating the administration allows the licensed nurse to focus on higher decision-making and coordination of care while providing the appropriate supervision of the MedAids activities. In the work of this committee, a comprehensive plan has been proposed to develop regulation of the minimum requirements of training for a MedAid to support the safe administration of medications within the nursing home setting. Moving from an instructor approval to a training approval will allow the RN instructor to use all components of nursing practice to assess learner and facility needs, identify the knowledge gaps, and allow the RN instructor to develop teaching plans to close those gaps. Providing a content outline with minimum training standards will allow the RN instructor to assess current best practices and update the curriculum as needed while maintaining the minimum standard for training. The required annual report will monitor training compliance and also collect data of the number of learners being trained for this skill within the nursing home setting. Through the development of a new process, an ongoing assessment of the training and current clinical practice will be facilitated through the development of the training by the RN instructor and the collection of information through the annual report. In addition, board staff will continue the work of this charge by beginning the rulemaking process that will involve an opportunity for open comment and then making information available once the rules are implemented. In addition to the specific dissemination plan Dr. Caparell shared, the work will continue as information is provided on the Board of Nursing website, on social media platforms, and will be added to the content of existing presentations. A required periodic review of the rules will occur to establish the need for revisions when indicated, and board position statements are reviewed for relevance to current practice, laws, and rules. So in summary, the proposal you've heard today includes the minimum training requirements provided in a content outline, It provides instructor resources for toolkits, competency checklists, and teaching resources. A position statement providing clarification of the role of the nurse when delegating to med aides in nursing homes. Education for the nurses in nursing homes who will delegate medication administration with dissemination specifically to the nursing home setting. And rule revisions to provide minimum training standards, instructor and applicant requirements, and a process of annual reporting to monitor compliance. The intent of this comprehensive proposal is to provide the minimum medication aid training requirements that will support the safe administration of medications in nursing homes. This concludes the summary.
Thank you, Stacy. So I believe we've done this already, but in the case there are questions or discussion, this is now that time to discuss any of the proposals that have come forth today, or to ask questions or make comments regarding any of the information that has been provided. Okay, all right. So, yes, Dr.
Just
Shaw.
make a recommendation as this gets implemented, whenever it does, I'm assuming later this year, that we have some way of, maybe back to the board, trending the data around medication aid training, maybe coming back quarterly or once a year, probably that's better, to just provide an overview of, the progress of and the state of medication aids. And I think that just really helps us continue to inform evolution in this role, and perhaps even how it can be used in other places in the future.
Thank you, Dr. Shaw. Absolutely.
I wanted to thank all board staff who have worked so hard, and they've really been in the weeds and really tried to bring this to make it easier for board members, and what a tremendous job you've done. Stacy, you led it and answered questions well, so thank you. Also wanted to thank Angie Mathis, because I know you were instrumental in the rule revision writing as well, so thank you. Position statement, yes, because you're doing all the position statements. Yes, Angie's doing all the position statements and shortening them. So they're not 10 pages. You can 1 or 2 pages, what nurses need to know and to move on. So thank you.
I also wanted to add, I appreciate the research as usual and the peer-reviewed articles and the other articles that were provided. One in particular outlines every state and what we, even in North Carolina, in our situation where we have the same, title of a position regulated by 2 different departments was highlighted. So seeing all the states there listed was amazing. So y'all did a great job of finding appropriate research to add value to the position statement. So thank you for that as well.
Yes, and I would also like to add, to not be redundant at the same time, I really liked how you captured the recommendations from the presenters and from the surveys. And I love curriculum. Curriculum is just my favorite. It excites me. My husband said that hopefully I will never get Alzheimer's, but if I am and I'm placed in a long-term care facility to keep me busy, he said he would recommend that they give me something and tell me it's curriculum. And so, that would, keep me busy all day. So, but anyway, if there are not additional comments, we will go to summary and recommendations, where we have reviewed and received a comprehensive proposal on the training and role of medication aids in nursing homes. We recognize the board has jurisdiction over faculty and applicant requirements, education and training materials, and the delegation of medication administration from a licensed nurse. To support our mission of public protection, it is the desire of the committee to direct staff to proceed with rulemaking from 421 NCAC .0403 and 21 NCAC 36.0406 as presented, and implement the dissemination plan for the education of nurses working with medication aids in nursing homes. And so with that being said, I need a motion to direct staff to proceed with the rulemaking and implement the dissemination plan.
Madam Chair, I move to direct staff to rulemaking and proceed with the implementation plan.
Yes, thank you. Dr. Steele has moved to direct staff to proceed with rulemaking and implement the dissemination plan. Is there a second? Seconded by Andrea Jepson. I will now call for a vote.
If-
All in.
If I may just make a point of clarification, it would be to take these rules to the full board
Okay.
before proceeding with rulemaking.
Madam Chair, I'd like to modify my motion to move to take all of the rules before the full board in May.
Thank you. Thank you, Meredith. Thank you, Dr. Steele. So the motion has been amended and to include that we will take this to the full board in May. Okay, and so with that, is there a second? Seconded again by Andrea Jepson. All in favor, show of hands. All right, we have it now. The motion carries. And in that regard, just a reminder that our next meeting will be scheduled for August the 11th, 2026. And if there are no further information or revisions as requested, this actually concludes our charge for the Education and Practice Committee. So we don't need that meeting for August the 11th. You can't say we hadn't given you anything, right? So in that regard, I now need a motion and a second for the meeting to adjourn.
Madam Chair, I move to adjourn.
Thank you. Dr. Steele has moved to adjourn. Is there a second? Kelly has seconded the motion. All in favor by show of hands. Our meeting is now adjourned. Thank you.